So I'm happy to be here today in Houston, Texas for SOHO 2019, and I'm going to be talking today about myeloma bone disease and specifically how we can best manage that. So bone disease in multiple myeloma is a significant problem. The myeloma cells grow within the bone marrow, which is right next to the bone, and as a result that causes bone to be lost. That can cause generalized bone loss, but also local bone loss, what we call osteolytic lesions to develop, and that increases the risk for fractures, and it also increases the risk for things like spinal cord compression. So it's really important to try to limit bone loss. We have two different classes of medications that have been approved for the treatment of bone loss in multiple myeloma. The first are the bisphosphonates, which actually cause the cells that cause bone loss to be undergo basically cell death, what we call apoptosis. And the second class of medication is a medication that was approved by the FDA more recently, about a year and a half ago, called denosumab, or trade name is Xgeva, which actually causes osteoclasts not to form in the first place. And it's important to recognize that these medications work slightly differently. So the bisphosphonates, by causing osteoclast cell death, limit bone loss sort of for a long time. On the other hand, denosumab, or Xgeva, basically inhibits osteoclasts from forming in the first place. And this medication needs to be provided on a regular interval. Typically it's provided once monthly, and if it's not continued to be provided, the challenge is that those osteoclasts that are prevented from forming basically can build up, and then if that block is not continued to be provided by providing the denosumab, then a large number of those osteoclasts can actually form active osteoclasts to then cause bone to be lost. And we know that that's a significant problem. Particularly, we know that from patients who also received this medication in osteoporosis, so that in patients who receive denosumab, they either need to continue receiving this medication on a regular basis, sort of ad infinitum, or at some point they need to transition to a bisphosphonate so that those same osteoclasts can then be killed or undergo apoptosis by the bisphosphonate. So these are things I think that are important for clinicians and patients as well, as we optimize bone care in patients with multiple myeloma.